Right. Well, looks like we have almost 30 participants, and so I think we'll get started. My name is Jasdeep Gill. I'm one of the fourth-year psychiatry residents, and I'm very excited today to introduce you to our Grand Round speaker, Dr. Francis Liu. Dr. Liu is currently a Luke and Grace Kim Professor Emeritus of Cultural Psychiatry and Professor of Clinical Psychiatry at the University of California, Davis. Dr. Liu completed his bachelor's degree in sociology at Columbia College and his medical degree at Dartmouth Medical College. And following that, completed his psychiatry residency training at Mount Sinai Hospital. He has extensive experience in the areas of public hospital psychiatry, cultural psychiatry, cultural competence and diversity psychiatry, and religion and spirituality, and also training of psychiatry residents and also faculty. He was involved in the development of cultural competence standards and performance measures within the Federal Substance Abuse and Mental Health Service Administration Center for Mental Health Services, in addition to spearheading diversity and cultural competency training programs across institutions throughout the United States. He's received multiple national and international awards, including the American Psychiatric Association Distinguished Service Award and a Lifetime Achievement Award from the Society for the Study of Psychiatry and Culture. He's also been awarded the American Psychiatric Association Kung Po Sue Award that recognizes an individual that has made significant contributions towards understanding the impact of Asian cultural heritage in areas relevant to psychiatry. In addition, he's received an award for the Special Presidential Commendation by the American Psychiatric Association for Research, Publication, and Advocacy for Cross-Cultural Psychiatry. Please give us a warm welcome to Dr. Liu, who will be presenting today for an outline on cultural formulation and cultural formulation interview and on tools for culturally and structurally competent care.
Thank you. Thank you very much, Dr. Singh, for your kind introduction. And I will share my screen now. Handouts were distributed, I believe, this morning. One handout has a PDF of all of my slides, lengthy excerpts from the DSM-5 text revision that was just published March 19, as well as articles about the cultural formulation interview. The second handout is a 40-page handout on diversity, equity, inclusion, anti-racism resources. Today, I will be speaking about two tools in the text revision that you can immediately employ to improve culturally and structurally competent care. I have no disclosures. Feel free to email me if you have any further questions after today's talk. Feel free to type in the chat, by the way, as I am talking, your questions so I can answer them at the end. We'll have about 5 minutes at the end. So please type your questions in the chat. Here are our learning objectives. We will be focusing on our tools and the 12 supplementary modules. Before getting to that, however, I just wanted to very quickly and briefly, so we're all on the same page, have a common understanding of what is cultural competence and why is it important, looking at quality of care issues as well as training. I'm just going to focus on the ACGME accreditation standards for general psychiatry residency training. And I'll say a word about the concept of structural competency. Then we will go through a roadmap of where cultural issues appears in the text revision. And I will highlight changes from DSM-4 to the present day. The Joint Commission that accredits healthcare organizations has adopted this one-sentence definition of cultural competence based on a earlier federal definition: the ability of healthcare providers, individual clinicians, as well as healthcare organizations, systems of care, to understand and respond effectively. And just want to highlight, there are two different verbs there. Understanding is one thing, responding effectively is another. To the cultural and language needs, language is made explicit here because of its obvious impact on communication. Needs brought by the patient to the healthcare encounter. So this is a everyday phenomenon with every patient that we see. And here's my amplification of this concept. I see different elements, different parts of cultural competence, like different parts of the elephant, and that this is a journey, ongoing discovery. And it starts with oneself, having your own understanding of your cultural identity, values, prejudices, and biases. Then the critically important attitude of humility or cultural humility about the limits of your assessment, treatment, knowledge, and skills, meaning be open, be curious, and ask, don't assume. Then the attitude of valuing diversity, that an awareness and sensitivity to cultural differences is important in our work, as opposed to saying, well, we're all Americans, so I treat all my patients the same. Then ensuring safety about the power dynamics between the clinician and the individual. We know that there is a power differential already. And lastly, how do we respond to cultural diversity? By adapting our assessment and treatment. And that's what these two tools will help us actually do. So I just want to mention this landmark report that came out over 20 years ago from now the what was used to be called the Institute of Medicine, now the National Academy of Medicine, that looked at our healthcare system and saw that we needed to improve it in 6 ways, 6 quality outcomes as goals for transforming our healthcare system. So one was patient-centered care, providing care that is respectful of and responsive to. So again, see that respectful of and responsive to individual patient preferences, needs, and values. So that's aligned with the concept of culturally and linguistically competent care. And then equitable care, providing care that does not vary in quality because of cultural identity variables. And this is aligned with the concept of reducing or eliminating disparities in care. Now, the key word here is quality. It does not say providing care that does not vary because of cultural identity variables. That's like the idea, well, I treat all my patients the same. I would argue that if you don't pay attention to these cultural identity variables, you will not be providing quality care or equitable care. So now turning quickly to the training standards, and again, I'm just mentioning this to kind of give you some connection between what I'll be talking about in a moment to show the relevance of why I'm doing this. Many of you, I'm sure, all of you are involved with residency training. And so, as you know, there are these accreditation standards for the training programs, and it asks that the programs to develop competencies of the residents, and there are 6 core competencies. So for the patient care one, the standards actually reference the book that I mentioned just a moment ago, and says the obvious, that residents must demonstrate competence, and must is a very important word there, in the evaluation and treatment of patients from different cultural backgrounds. Now, what might be related to that? What might be related to that? Well, then we have this subcompetency under the core competency of patient care: must demonstrate competence in forging a therapeutic alliance with these patients. Now, what might be related to that? And then we have this subcompetency under medical knowledge, understanding the cultural elements of the relationship between the resident and the patient, including dynamics of differences in identity, values, preferences, and power. So this, do you see, this is an element of the therapeutic alliance. And now this ties in directly with part 4 of the outline for cultural formulation that I'll be coming to towards the end of my talk. And here's another core competency, being able to communicate with patients from diverse cultural backgrounds. And here's yet another core competency is professionalism, sensitivity, and responsiveness. Again, you see two things, sensitivity and responsiveness to a diverse patient population, broadly defined. It's not just race and ethnicity, broadly defined, as you can see. And this is the last core competency that I wanted to mention, was systems-based practice. This is a subcompetency under systems-based practice. Must demonstrate awareness, responsiveness to the larger context and system of care, including the social determinants of health, as well as the ability to call effectively on other resources to provide optimal care. Now, this is very aligned with this concept of structural competency. This is a term that Jonathan Metzl from Vanderbilt, Helena Hansen, now at UCLA, coined in 2014, and in 2018 they defined structural competency in this way, which is to encourage practitioners to recognize how social, economic, and political conditions produce health inequalities in the first place. So this is to understand the institution's neighborhood conditions, market forces, public policies that lead to these inequalities. And this needs to be addressed at the physician-patient level as well as at the social action level beyond the clinic walls. So I'll come back to this. So you have cultural competency and you have structural competency. Now turning to the TR, and I'll just call it the TR, there are 3 sections. Section 1 is the introduction, and what's in yellow is added, and what's underlined are the take-home points. So there used to be a section in the introduction called cultural issues. Now it is cultural and social structural issues. You see how that's brought together, cultural and social structural issues? You may be asking yourself, well, what are these social structural issues? Well, I'll come to that in just a moment. But that's very important, moving from just cultural issues to cultural and social structural issues. It's not just semantics. This is quite important. And then there are these cultural concepts of distress. That's a very important term that you will see in a moment. And here we have 3 subtypes. And in the introduction, these 3 subtypes are defined. So the idiom of distress is like the chief complaint. The explanation or cause is the explanatory model that the patient has of why this is happening. And the syndrome is a clustering. Think of clustering of idiom and causes and other features. Then what was added was this impact on racism and discrimination on psychiatric diagnosis, bringing this idea more central to our thinking about diagnosis. And so these are some ways that this is manifested throughout the TR, that the term racialized is used instead of race or racial to highlight the socially constructed nature of race instead of a biological nature of race that many people still think it is. And ethno-racial is used rather than ethnicity or race. And terms like minority and non-white and Caucasian tend not to be used. So we don't have this minority-majority hierarchy. Now, section 2 is the bulk of the DSM, And here we have the narrative sections that describe the disorders and the diagnostic criteria and the codes. And in those disorder narrative sections, for some of the disorders, there are sections of the narrative labeled culture-related diagnostic issues or sex and gender-related diagnostic issues. Again, the yellow is the added. And then there's a group of conditions called other conditions that may be a focus of clinical attention. These are now termed the Z codes primarily rather than the V codes. So that's a change. So, the text revision, that means the text was revised, and that includes those sections that I'm speaking about. And those sections provide helpful descriptions of things such as variations in symptom expression or causes, or why there might be differential prevalence across demographic groups for these disorders, cultural norms that affect the level of perceived pathology, and finally, the attention to the risk of misdiagnosis. So the misdiagnosis of schizophrenia in African Americans is noted. Now the Z codes are described. There's a little introduction that describes them, and you have all of this in your backup material. These are conditions or psychosocial or environmental problems that may be a focus of clinical attention, or may affect the diagnosis, course, prognosis, and treatment of an individual's mental disorder. They are relevant. And now these are called Z codes to align with the ICD-10. And what was added here, very important, is in yellow at the end, is that why might we actually put these on the diagnosis? We could include these in the diagnosis. And there are two additional reasons. If these conditions play a role in the initiation or exacerbation of a mental disorder, or if they constitute a problem that should be part of the management plan. So these are relevant to our working with mental disorders, but they themselves are not mental disorders. And that's why these tend to kind of be forgotten. If they're not mental disorders, how are we involved as psychiatrists? And we often can't bill for these or get paid to even pay any attention to these. But that is changing now, and I'll get to that in a moment. But here are categories of these Z codes, and for each of these categories, there are specific codes. I'll give you some examples in a moment. New was suicidal behavior and non-suicidal self-injury. And here are more categories here. Now, the reason why I'm bringing all of this up is because these relate to the social determinants of mental health. The next slide is by Michael Compton and Ruth Shim in their latest thinking about this concept. You can see in the middle here are 16 social determinants of mental health. Now, the 10 in yellow were ones that they wrote about in their book of 2015 with that title, and that's referenced a little bit later. The 6 in white are new ones that they have added. So in the lower left corner, we have adverse early life experiences. We've known for over 20 years that this is a social determinant of mental health. And then next to it, we have discrimination. And above that, we have things like homelessness and food insecurity, unemployment, which have all gotten worse with the pandemic. And then in the upper right, for example, we have climate change. Now, these social determinants of mental health, looking upward, impact on adverse health outcomes and mental health outcomes. That's why these are important. So we have the biomedical determinants of mental health and the psychological determinants of mental health. And yes, we need to keep in mind this category of social determinants of mental health. One last thing is below these 16 determinants, or if you will, the upstream factors, are these public policies and social norms. This is part of those social structural factors that's part of structural competency. We address these social determinants and the social structural factors of policies and norms through structural competency. So under abuse and neglect category, we have these specific ones, for example, and for relational problems, again, we have these specific ones. This is all in your backup material. You will find these. And then for the category of problems related to social environment, here are some specific definitions of codes. So we have this one on bullying and teasing. And again, I think you understand why this is important. And so there is a diagnosis for this. And then we have acculturation difficulty, adjusting to a new culture. And we have this one, which I think is very important, target of perceived adverse discrimination or persecution. And again, broadly defined, you see. And of course, you know, this has become quite relevant in the last few years as these sorts of things have been happening, that people have been experiencing this. And here is yet another category, and we have the specific code of exposure to disaster, war, or other hostilities. And so we can see very graphically in Ukraine how the war there has certainly exacerbated mental disorders. And this is the last example, is religious or spiritual problem, which I helped to get into the DSM-4 in 1994. These are distressing experiences such as losing faith in God, or the feeling that God is punishing me for my sins, or I have a mystical experience, which is very distressing. These should not be seen as signs or symptoms of a mental disorder, but rather as a religious or spiritual problem. Now, in section 3, that's entitled Emerging Measures and Models, there is a section entitled Culture and Psychiatric Diagnosis. And again, you have all of this in your backup material. There is the outline for cultural formulation, which first appeared in Appendix I, the 9th appendix in DSM-4, was revised for DSM-5. New in the DSM-5 was the cultural formulation interview, unchanged in the TR. And then there is a section entitled Cultural Concepts of Distress, which expands on those 3 definitions that you will find in the introduction. And now we have 10 examples. There used to be just 9. So this is the outline, and I will go into this in greater detail in just a moment. There are 5 parts. The first 4 are fields of interrelated information that we ask the clinician to gather, to understand. You know, what are the cultural issues in this case? Well, here you have kind of a roadmap as to what the cultural issues are. What's the cultural identity of the individual? What are the cultural concepts of distress? What are the stressors and supports? What are the cultural features of the relationship between the individual and the clinician? And you can see how that ties in very directly with the accreditation standard that I referenced earlier. Added in the TR was treatment team and institution. So we're now looking at this kind of the social structural aspects of the relationship beyond just the interpersonal one with the clinician. And then the last part is, how do we summarize all of this, and what is the impact on our differential diagnosis of mental disorders, Z codes, and how does this then impact on our treatment plan? That's the responsiveness part. That's where we take the information and apply it. Now, for the DSM-5, the work group on cultural issues headed by Roberto Luis Fernandez at Columbia, and I was part of that large work group, created the cultural formulation interview to help clinicians gather the information for the outline by providing 16 questions in the core patient version. There is also an informant version, which is pretty much the same with the addition of one more question. Now, these are printed in the TR. In addition, there are 12 supplementary modules which you would access by going to that website. And these provide additional questions for deeper dives into specific parts of the outline. So for example, there are 3 questions for cultural identity in the core CFI. If you want to ask more questions, go to this supplementary module and you'll find 35 additional questions. Now, the last 4 modules in the right-hand column speak about specific patient populations. So if you're working with children and adolescents or older adults or immigrants or refugees or patients with religion or spirituality, then I would strongly advise you to pull out that supplementary module to help you, understand the cultural issues with the aid of these questions. You see, the questions are meant to facilitate your gathering the information. So this is what it looks like in the TR. And so you can see it's not just a list of 16 questions, but there's a guide to the interviewer on the left-hand column and instructions and actual wording you can use in the right-hand column. And the first question is, well, what brings you here today? So hopefully you're asking that question already. And now I'm going to go through the 16 questions in the order they appear in the CFI and relate that back to the outline. Now, they're not in the same order because we felt the natural place to begin was what brings you here today, rather than what is most important about your background or identity. So wherever you see problem in caps and brackets, we would like you to use the patient's own words whenever possible. So what brings you here today? Patient might say wind illness. Well, sometimes people have different ways of describing their problem to their social network. How would you describe your wind illness to them? And what troubles you most about your wind illness? Then the next 2 questions relate to cause. Why do you think this is happening to you? And what do you think are the causes of your wind illness? And what do others in your social network say are the causes of your wind illness? So now these first 5 questions relate to part B of the outline, the cultural concepts of distress. Again, what's underlined is the take-home points. What's in yellow was added. So as you can see here, the 3 subtypes are mentioned there, the idioms, the explanations, and the syndromes. And as I said, those are defined in the introduction. You have that in your backup material. And then the level of severity and meaning of the distressing experiences should be assessed in relation to the norms of the individual's cultural background. That's why we have those 2 questions around the social network. And then what's in yellow is added to give you more detail about this. And again, what was added here to, again, give you more description of this. And then the last part there, assessment of coping and help-seeking patterns should consider professional as well as traditional, alternative, or complementary sources of care. Now, we will come back to this at questions 11 to 15. And so here we're interested not only in visits to the psychiatrist or psychologist or social worker, but also Tai Chi, acupuncture, herbal medicine, shamans, and so on. Now, in that section 3, there's an entire section entitled Cultural Concepts of Distress, and there you'll find out more information about the cultural concepts of distress. And then there are 10 examples that are described, and hikikomori, originally described in Japan, was added. Now, here you have 10 examples in a table. In the left column are the actual names of these concepts. And after each name, there's a description and then related conditions in DSM-5 TR, because these conditions, there's not like a one-to-one correspondence with a DSM-5 TR mental disorder. You can see these in several of the disorders. So you have the name, and then in the middle there, you can see which of the 3 subtypes that they are. So nervios is an idiom of distress, but it is also part of ataque de nervios, which is a cultural syndrome. So you see how nervios is part of that cluster of phenomenon of ataque de nervios. And then in the far right column are places in the world where this was originally described, and of course we're interested in that because people come from all over the world to the US. Now, this is a cautionary tale as to why we should pay attention to this cultural concepts of distress. So this is based on a true life story in the mid-90s of a Hmong family, Hmong being an ethnic group from Laos, where the infant or the child had a grand mal seizure disorder as diagnosed by a neurologist and pediatrician in the Central Valley of California. And they had a biomedical explanatory model for it, and they had a biomedical treatment, which was medication. However, the family called it the spirit catches you and you fall down. They didn't call it a grand mal seizure disorder. And they had a supernatural cause related to this phenomenon, and their preferred method of treatment was use of shamans to help deal with this. And unfortunately, there was never an understanding of this or a negotiation, and it led to medication noncompliance. And the child went into a prolonged grand mal seizure and left in a vegetative state and died 12 years later. Now, the next 2 questions in the CFI relate to stressors and supports. Are there any kinds of support that make your wind illness better? And are there any kinds of stresses that make your wind illness worse? It's pretty straightforward. I mean, we generally ask these questions, all the time anyway. Now, these 2 questions relate to part C of the outline. And again, what's underlined are the take-home points. What's in yellow was added. So the first sentence pretty much says it all. Identify the key stressors and supports in the individual social environment that may include both local and distant events. I'll expand on this in a moment, but stressors and supports in the social environment. Now, very important was this next sentence, which was added here. These include the social determinants of the individual's mental health, such as you can see, those things: access to resources, opportunities, exposure to racism, discrimination, and so on. So this relates to those Michael Compton, Ruth Shim, 16 social determinants of mental health. And this relates to those Z codes. Now, in addition, this is a further description of this section. There are 3 main domains to think about, okay? Religion and family, which were in the DSM-4, and social networks was added in DSM-5. So keep thinking of religion, family, and social networks, okay? That can either cause stress or provide support. Those things could either cause stress or provide support. Someone needs to mute themselves out there. So again, just expanding on this, think of the interpersonal relationships. These are the local phenomena. These are happening like here and now, right now, across those three domains. But also think of, more broadly speaking, of those Z codes that relate, that map onto the social determinants of mental health, which can be local by geography or time, or distant by geography or time. Now, what do I mean by that? So take something like the shooting in Buffalo that just happened. Well, that's if you were living in Buffalo, that's pretty local, here and now, happening in our neighborhood. Okay, but white supremacy and so forth has a long history in America, so it's distant by time and also has pervaded much of the United States. Or take climate change. So you have wildfires in your part of the world related to climate change. That's happening here and now. The smoke that you're experiencing and so on, the fires, and that's here and now. That's local by geography or time. But climate change is also distant because it's affecting the whole earth, and also it goes back hundreds of years. So again, whenever religious issues come up, go to that supplementary module on religion, spirituality, and moral traditions. There are like 19 questions. These are the categories of the questions to help you understand the role of religion and spirituality in the person's life. And family, think about using a genogram, think beyond the nuclear family to the extended family, and how family is related to different kinds of characteristics that may be important to what's happening with the person. Now, Pamela Hayes, in a book that I'll reference in just a moment, has written about culturally related strengths and supports. And so she lists these. So the idea is put on the cultural lens to see if there might be supports or strengths that you might otherwise not see that could be optimized in your work with patients. We're always looking for ways of supporting our patients. So here we have things like extended families or religious communities or involvement in political or social action groups. Certainly that's very important to some of our patients. And then here we have things like caring for animals and so on. So here are those books, the Compton and Shim book that I highly recommend, and then Pamela Hayes's book that just came out in a 4th edition in January, addressing cultural complexities in practice, and then Monica McGoldrick's book on ethnicity and family therapy, which has 52 chapters, not only on Japanese families and Vietnamese families, but also Italian families and Irish families. Now, moving on to questions 8 to 10, this relates to cultural identity. For you, what are the most important aspects of your background or identity? And are there any aspects of your background or identity that make a difference to your windowless? How does that link together? And then we have a second pass question. Are there any aspects of your background identity that are causing other concerns or difficulties for you? So this relates to part A, the cultural identity. This is what we see in the DSM-4. You can see reference to race, ethnicity, and biculturality and language. Added in DSM-5 was an explicit expansion of these cultural identity variables to include these as well. So it's not just race, ethnicity, and language and so on, but these additional things we should be thinking about. And all of this was expanded yet again in the TR. So again, what's underlined are the key take-home points in yellow was added. So there's more, specificity about these cultural identity variables, and you can see additional ones were added, including the residual term among others, meaning this is not an exclusive list. There are other things here. And then the very important sentence, note which aspects of identity are prioritized by the individual and how they interact, intersectionality. Very important. You can't tell someone's cultural identity just by looking at them. You have to ask, you have to engage them. And then we're also interested in not just silo city, like a woman or a Black or a person from rural America, but how these intersect. Now, okay, and the rest of this is pretty much the same as before. Let me give you two schemas to help you understand what I'm getting at. First is the addressing framework from Pamela Hayes's book, where she uses the word addressing as an acronym to help us remember these cultural identity variables. Okay, that's addressing. Now, language is over in brackets to the right because there's no L in addressing, yet it's a very important cultural identity variable. So this is not a complete list, but it's the concept of a number of factors and what is the intersectionality. She writes about that quite extensively in her new revision. Here's another schema from a great website, Think Cultural Health. And so if you look at linguistic characteristics at 8 o'clock and go clockwise to 5 o'clock, you see the different cultural identity variables here and how they intersect. Okay, and in this diagram, we have health beliefs and practices. That's part B of the outline, and environment is part C of the outline. So again, both basically cultural humility, ask, don't assume. Asian is an umbrella term, and national origin doesn't define a homogeneous ethnic group. Ultimately, we need to ask because we want to know how the person prioritizes this. And cultural identity is centrally related to all of the other aspects of the outline. And we ask that second pass question because sometimes there may be, for example, intrapsychic conflict, cultural identity conflict. So how much am I gay? How much am I straight? How much am I an American? Let's say a Vietnamese adolescent who only speaks English, whose parents are traditionally acculturated. Well, he might be asking, how much am I an American? How much am I Vietnamese? How much am I religiously committed now as I was brought up, or am I now leaving my religious background? And this can happen with interpersonal relationship conflicts between that traditionally acculturated Vietnamese parents and the adolescent who's moving in the assimilation direction. And certainly at the social level, we see how this could be an issue. So questions 11 to 15 speak about asks us to understand self-coping and past help seeking and barriers to care. Very important because barriers that people have had in the past may impact, ability to get care now. And now questions 14 is a very important take-home question. What kinds of help do you think would be most useful to you at this time for your wind illness? That's one of the most important questions. And then the social network question, what does your social network have to say? So this references us back to part B of the outline. I mentioned that earlier, that last part of part B. And so as you know, patients can go to primary care first and then come to mental health, or they may seek these other practices before coming to mental health. And this is just some pictures of different approaches and just lists of different approaches. Now, moving on to the very last question of the CFI, and I know I have about 8 minutes left here before we get to the Q&A period. The last question of the CFI is one of the most important, and it just touches on the clinician-patient relationship. So sometimes doctors and patients misunderstand each other because they come from different backgrounds or have different expectations. Have you been concerned about this? And is there anything that we can do to provide you with the care that you need? Okay, so this relates to the fourth part of the outline. I'm sorry it's so busy. What's underlined is key. What's in yellow is added. So what was added here was treatment team and institution as well in the title. So we have identify the differences in the cultural identity between the clinician and the individual that may cause difficulties in communication and may influence diagnosis and treatment. Okay. And then what's in yellow here is added to give you more description of that. Now, very important, this is all retained from the 5. Experiences of racism and discrimination in the larger society may impede trust in the relationship. And this can then lead to problems as listed there, eliciting symptoms, misunderstanding what's cultural, what's psychopathological, and ultimately it may impact on the therapeutic alliance. So this ties in back to the accreditation standard that I mentioned earlier. So how do you operationalize this? Let me give you 4 steps and 4 examples. So the first step is for the clinician to understand their own cultural identity. Okay, that's really critical. Secondly, is compare the cultural identity of the patient to that of the clinician. So you can have like a little table. In the far left column, you have the cultural identity variables like age, race, ethnicity, gender, sexual orientation. In the center, you have the patient's cultural identity variables. And in the far right column, you have the clinician's cultural identity variables. And you look at the similarities and differences and how that might affect the third step here is how does it affect the relationship? How does it affect the therapeutic alliance? Again, we are concerned about this every day with every patient. So the idea is put on the cultural lens. What are the cultural features of the relationship here that's impacting on all of these things? And of course, one aspect of all of this that we need to keep in mind is the issue of bias. This can be either intended and explicit or unintended implicit bias. And this could go both ways, biases that the clinicians have towards the patients or the patients towards the clinicians. And of course, there are many kinds of biases, as you can see there, and they could be operating, just singularly or in combination. And, the origins of these biases could be, our own personal background or our culture or even our profession. So homosexuality was a mental disorder in the DSM until 1973. Okay, and then the fourth step is the most important one is that question. What would help the clinician to provide optimal care? So sometimes, in my first 2 examples, a cultural identity match may be quite important. Other times, it's increased knowledge and skills concerning these areas, and that can be done through a cultural consultation with a faculty member or trainee who may know about that culture, or a chaplain, or a community leader, or PubMed searches, books on these things. Okay, so let me give you 4 quick examples. I am Chinese. I was born in San Francisco, but I only speak English. And on this inpatient unit, a Chinese patient comes up to me and starts speaking Cantonese. So right there, we have a language difference. And that's obviously causing a problem in communication. So I need to respond by getting a trained interpreter or working through a clinician who speaks Cantonese, or maybe referring this person to a Cantonese speaking psychiatrist. You see, that's the cultural identity match. Second example, I'm a man. A woman comes in for the first interview, doesn't give much information. At the end says, well, I'd rather just speak to a woman psychiatrist. So what do I do with that? Do I say, well, patient is treatment resistant, passive aggressive, go down the psychopathology track? Or do I ask and not assume? And we find out that she's had a very extensive sexual abuse history and has difficulty trusting men. So there, a cultural identity match might be critically important. Third example, I'm a Biden Democrat, and a man comes in with a red cap that says, "Make America Great Again." And he looks at me and says, "Well, what country are you from?" So right there, there's a political orientation difference, and a bias is coming up immediately, and this is affecting our relationship. The last example is I'm an atheist. I ask the patient, "Well, what brings you here today?" And the patient says, "Well, I've lost my faith in God, and God is punishing me for my sins. So what do I do with that?" You see, do I stay silent? And the patient may feel ignored, not responded to, drop out of treatment. Or worse yet, do I say, "Well, why is God so important to you?" Do I begin to kind of psychopathologize the belief in God, and which could also lead to the patient dropping out of treatment? So what I've talked about today is the relationship patient and clinician, but this concept can apply across many other relationships. I'm going to have to move quickly here. This is the last part. Again, how do we summarize this? How does this impact on our differential diagnosis and our treatment plan? So the concept here is we want a complete differential diagnosis, because misdiagnosis can lead to mistreatment. And so how do you do that? One is to review those culture-related and sex and gender-related diagnostic issue sections, as well as review and add the Z codes that map onto the social determinants of mental health, so they can be addressed in the treatment plan. And there's the process of negotiating and managing a treatment plan to maximize adherence and compliance. Again, put on the cultural lens. Are there factors here that could improve this process? We're always concerned about, are the patients taking their medication? Are there any cultural issues involved here, as well as the biopsychosocial aspects? Because of time, I'm not going to go over this, but here are some books that'll be very helpful here. The best book on the outline for cultural formulation, the best book on the CFI. This is a great online training on the CFI. This is another e-learning program. And here, this is my last slide, are additional resources. There is a Society for the Study of Psychiatry and Culture. You can learn about it at the website. Transcultural Psychiatry Journal is the most prominent journal in this area. The second handout is that DEIA resource list, which I update every month, and you can Google that to get the latest copy. And structuralcompetency.org is a great website to learn about that concept of structural